Hello again, everybody. We're going to talk about burns here, and burns is very complicated. There's lots to know about it, so I want to just start off with a little introduction so you kind of know what the different burns are, the severities, and just sort of have a general overview of them before we go into the management, because the management is rather detailed. So we're going to go over just an overview of what we're going to talk about, the general management of burns, so you kind of have an idea of that before we talk about some of the differences and the various types of burns and the different severities. We'll talk about the types of burns, and this certainly isn't comprehensive. But these four are the major classes of burns, especially that you're going to be responsible for knowing on the USMLE. Those are thermal, chemical, electrical, and respiratory burns, and you can get respiratory burns from thermal and chemical sources. We'll talk about the severity of burns, first, second, and third degree burns, how you can tell those apart, how you estimate body area. That's going to be important for determining fluid resuscitation. All patients with burns to more than 10% of their body area will require Hello again, everybody. We are going to talk about burns here, and burns is a rather complicated subject to know about for the USMLE because so much of it depends on the type of burn and severity, and the management is rather complex as well because there's various complications that can come out of it. Most patients do need to be hospitalized. So I wanted to do a general overview of burns, just establishing some definitions, and then go on to more of the details of how we manage burn patients, whether we do it on an inpatient basis, which is going to be the majority of burn patients, or whether we do it on an outpatient basis. So we'll talk about the types of burns here, and the major four classifications of burns are thermal, chemical, electrical, and respiratory. Respiratory can come from a thermal or chemical source. We'll talk about the various severity of burns, and that's going to depend on the thickness, the depth of the burn in the skin. First, second, and third degree, we'll talk about how to differentiate those. And then we'll talk about how we estimate the body area of that the burn has, the patient has sustained. And then that's going to be important for determining how much fluid resuscitation we're going to deliver to the patient. Any patient with more than 15% of their body area burnt are going to require fluid resuscitation. So just as an overview, approximately 1.25 million patients per year in the U.S. present with burn injuries, and the management of burns is complex and depends on the location, severity, mechanism, be it thermal, chemical, and then comorbid conditions. So because of this, there are specialized care centers, burn centers, that are increasingly available to tailor individualized treatment for these patients. The emergent management for burns includes ensuring that the patient has an adequate airway, replacing fluids because there's third spacing with the injury to the skin. You'll get edema, that's going to remove fluid from your vascular space, and so it's important to replace the fluids to avoid hypotension and derangements in the patient's electrolyte levels. And then, of course, addressing any other injuries and assessing for emergent issues associated with burn injuries. The long-term management for burn injuries may include plastic or cosmetic surgery, and that's going to be more for the severe burns that affect the face, hands, feet, and perineum, as these can be disfiguring and debilitating. So just to quickly recap our anatomy of the skin. So we have the epidermis here, which is the outermost layer. The dermis is the layer in which the follicles run through, as well as small arteries and veins. The hypodermis is below the dermis, as its name would imply, and it contains sweat glands, small amounts of fat, and some larger arteries and veins. And then below the hypodermis is connective tissue, muscle, and bone. So knowing the anatomy isn't super important. Just know that you got epidermis, and below that's dermis, below that's hypodermis, and then below that you have connective tissue, muscle, bone, etc. So the basics of the general management that you're going to use to approach any burn patient are, of course, tending to the patient's ABCs, and that's going to be really important in patients who have respiratory injuries. So these are particularly patients who have breathed in superheated air or breathed in smoke. So, for instance, patients who are rescued from a burning house. These patients may require intubation. Also, full thickness burns to the chest wall may compromise ventilation. So we'll talk about this more in detail in the next section. Supplemental oxygen is something that's given to all patients who have burns, and this can be delivered either via nasal cannula or 100% oxygen via face mask, and that's for patients with smoke exposure. And that's particularly to displace any carbon monoxide that may be present on the hemoglobin. We want to establish venous access both for obtaining our laboratory workup and for fluid resuscitation. We're going to use 16 gauge needles here, and that's, of course, because we want to get the fluid in as quickly as possible. Laboratory workup is going to include CBC, BMP, type and cross match, carboxyhemoglobin, cardiac enzymes, chest x-ray, and EKG are going to be important in the respiratory and electrical burn patients. Fluid resuscitation will be done according to how much burn the patient has sustained, how much surface area. Then Foley catheter is placed for two reasons. One, we want to get a measurement of the patient's urinary myoglobin, because in certain cases the muscle can be damaged, and if the muscle is damaged, you'll have myoglobin in the blood, and that can injure the kidney. But we also want to insert a Foley catheter because we want to know how much urine the patient is producing. If the patient's not producing enough urine, we're going to need to give more fluids, speed up the fluids. If they're producing too much, then we can probably slow it down. So it's both for obtaining a urine sample and for monitoring the urine output. Inserting the NG tube is important for decompressing the GI tract for reasons we'll talk about in the next section. And then burn care, localized burn care, and pain control are also important peripherally once you've tended to all your immediate management and your diagnostics. So the types of burns include thermal. This is caused by contact with fire, steam, hot objects, or prolonged exposure to the sun. Some people would call prolonged exposure to the sun solar burns, but this is also due to heat, radiation from the sun. So this can be a wide range of burns. Chemical burns are caused by exposure to extreme acids, such as battery acid, hydrochloric acid, various things that you can encounter in a chemical laboratory for patients who have that kind of occupational exposure. Or it can also be due to exposure to alkalines, such as Drano and various fertilizers, again, on occupational exposure. Alkaline burns tend to be worse than acid burns, and that's because alkaline burns tend to penetrate the skin a little bit more and cause liquefactive necrosis of deeper skin layers than the acid burns do. Electrical burns are caused by electrical shock, or in rare cases, lightning strike. Notably, the electrical burns are more severe than they appear outwardly. So if you have a patient who's gotten an electrical shock or rarely has been struck by lightning, just looking at their injury, just looking at it based on their appearance, that's not enough. With the electrical burns, the skin itself is not usually is injured as much as the deeper tissue. So this is something to keep in mind. Also, it's important for the electrical burns to keep in mind the other complications of exposure to electricity, namely arrhythmia. Respiratory burns is damage to the respiratory tract. This can be either due to thermal or chemical inhalations, and the major concern here is respiratory compromise and carbon monoxide exposure. Circumferential burns are burns that are usually either on the chest wall or on the extremities, and it's a burn that goes, just like its name implies, around the entire circumference of the chest wall or the extremity. And this is important because when there is edema surrounding the extremity or the chest wall, and there's nowhere for that pressure to go from the edema, it will compress on whatever structure it's surrounding. So if it's surrounding your forearm, it can compress upon the nerves, it can compress upon the vascular structures, or if it's on the chest wall, it can interfere with breathing. And so in these cases, and usually these are second or generally third or fourth degree burns, in these cases, escharotomy is indicated to get rid of the pressure, to reduce the pressure so that you don't damage any tissue. This is somewhat analogous to compartment syndromes. In pediatric patients, it's important to be vigilant for symptoms consistent with child abuse. So some of the things here are to know the story behind the burn and make sure that the story matches the injury. So, for instance, if a pediatric patient has a scalding burn on their buttocks, that's probably going to be an abuse burn, as opposed to if the patient has a burn on the palmar aspect of their hands. Children tend to explore things with their hands, and so it's very common for a child to have a burn to their hand if they get a burn somewhere. Also be suspect of burns that are pattern or shaped. That usually indicates that there was some kind of object that was pressed onto the child. But do know that injury to the palmar hand is often not consistent with abuse. Also look for other non-burn symptoms consistent with child abuse, such as bruises of various ages, so forth. So here's some burn patterns. So if you notice like these kinds of fork patterns or cigarette burn patterns, or certainly a steam iron pattern, these are all often consistent with abuse, but you have to take into consideration the entire story. So just because you have certainly a child could grab at mom's curling iron with their hand and get an injury on their hand, and that doesn't mean that they were abused. But if, for instance, they have a hot plate to their buttocks or a cigarette burn to their legs or their arms, that's more consistent with abuse. Okay, the severity of burns varies based on the depth. So first degree is the least severe, and third degree is the most severe. And also there's a classification known as fourth degree, which is even more deeper than third degree. But formally, first, second, and third degree burns are how we classify the depth of burns. So first degree burns are superficial, and in this case, the burn is restricted to the epidermal layer, that outermost layer. And most commonly, this is due to sunburn. So if you get a sunburn outside, your skin turns red, that is a first degree burn. The tissue is going to appear red, erythemic. It's going to be painful, but what you will note is that it blanches with pressure. And then also there's no edema. So you could have a circumferential first degree burn, but that's not going to require any kind of addressing other than addressing the first degree burn. So you don't have edema in first degree burns. In second degree burns, these are partial thickness. So this is where the burn extends through the hypodermis down into the dermis. So because the dermis is separated from the hypodermis, what you can get is a blister. And a blister is just a collection of fluid or air in between the dermis and hypodermis. So you may note the blistering that's present. You may see the dome over the blistering, or the blistering might be open, and that would appear as desquamation. The tissue may feel moist. This is also very painful. Sometimes there is edema associated with second-degree burns, but sometimes not. So that's going to depend on the severity. Third-degree burns are full thickness, so this extends into the subcutaneous tissue. Remember that the nerves go through the subcutaneous tissue, so in this case, these are not going to be painful. There may be some pain, and that's only because there might be first or second degree burns surrounding the third degree burn, but the third degree burn itself, by definition, should not be painful. It's also dry and leathery appearing, and it does not blanch with pressure. There may be burnt connective tissue present, and that's known as eschar, and that can appear white or black. Fourth degree burns refer to burns that include damage to even deeper tissue, such as muscle or bone. Okay, so here's your first degree burn that just goes to the epidermis. Second degree burns that go through the dermis, and that can cause the desquamation and blisters. And then third degree burns go down into the hypodermis. And this is where you get the eschar formation. So superficial burns, you have painful, no edema, redness, blanches with pressure. Partial thickness burns are blistered, moist, painful. Full thickness burns are dry, leathery, discolored, no pain. And so full thickness burns where we're most concerned about the edema and the circumferential complications. So here's a good example of a first degree burn. So we just note erythema, no blisters present. That might be some blisters down there, it's hard to tell. This is mostly all first degree burn here. Another first degree burn. So this looks like a woman who went to the tanning booth and noticed that there's lines here, tan lines here. So this looks like a tanning burn, suntan. Sunburn, rather. Here's another first degree burn. And another one. Notice there's some desquamation here, so this is an area of second degree burn here, but this is first degree. Here's another first degree burn. And so forth. Note the pattern here, broad pattern. This is another sunburn. Okay, so here's a second degree burn around here. Notice the blistering, surrounded by some area of first degree burn. More blisters. This is second degree burn. More blisters. More. Here's some desquamation. Okay, so here's third degree burning. Note the black eschar that's present. You also have some blisters here too. Just remember, when you have second or third degree burns, you're going to have areas surrounding it that are also maybe first or second degree too. So it's not, your entire burn turns into a third degree burn or turns into a second degree burn. You can have areas in the same place that's injured that's first degree, some that's second degree, and some that's third degree. But if there's ever blisters present, then you know it's at least second degree or desquamation. There's another third degree burn with black eschar. It's a really bad injury. Third degree. More third degree burning. Okay, so how do we estimate body area? The general rule is we use the rule of nines, and this is a really good rule to know when you're working in the ED. Another rule that you can use is that it's about 1.25% of the patient's body area is the size of their hand. So either or, whichever you want to use. But on the USMLE, they tend to go for this rule of nines. So first we're going to talk about adults. So for adults, their head is 9%, each arm is 9%, and then you have your chest and abdomen, which are each 9% to make up 18%. Your back and lower back, buttocks, are both 9% each. And then both legs are 18%. So 9% anterior, 9% posterior. And then your perineum is 1%. So that, adding that all up, that comes up to be 100%. So your head is 9%, left arm 9%, right arm 9%, your chest and back are both 9%, that makes 18%. Your abdomen and buttocks are both 9%, that makes 18%. Your left leg, just think of it, anterior and posterior, those are both 9%, that makes 18%. Your right leg, anterior and posterior, are both 9%, that makes 18%, and then your perineum is 1%. So that comes out to be 100%. And the size of the patient's hand is about 1% of the body area, the total body area. Now, in children, because they're a little bit differently proportioned than adults, especially very, very young children, babies, the rule changes. So children are disproportionate to their head. So their head is a higher proportion to their bodies than adults are. So with small children, the head is 18% rather than 9%. And this is made up by the legs collectively being 27% rather than collectively being 36%. So we, instead of saying the left leg is 18% and the right leg is 18%, we just say that they're both 13.5% or 27% together. So you take away 9% collectively from your legs and add that 9% to your head, and the rest is the same. All right, so that's the difference. And this is for small children. So as you go from baby to adult, the difference gradually becomes less and less. So for a 17-year-old, you could probably use the adult classification, but for a 4-year-old, you'll probably want to err more towards this classification for babies. Okay. So determining fluid resuscitation, this is really important. So remember that when you have second or third degree burns, there is going to be a level of edema, especially in third degree burns. And anytime the patient has 15% or more of their total body area burned, we need to resuscitate the patient with fluids because they're going to have third spacing, and ultimately that's going to result in dehydration if not treated properly. So the Parkland formula is the formula that I see used the most, and on USMLE answer explanations, both from USMLE World and from Kaplan, I've seen this formula cited the most. So this is the one that I would know for the USMLE. This is the one that I would use in clinical practice as well. So the Parkland formula is the percentage of area burned. And by percentage, don't use a decimal. You use the actual number. So if it's 25% area burned, then this is going to be the numeral 25. If you use 0.25, it won't come out right. So 25 or 15 times the patient's weight in kilograms, and then multiply that by 4 milligrams per kilogram. And that's going to tell you the amount of Ringer's lactate that you should use for fluid resuscitation. That will be your V value. Okay, we'll come back to that later. And this is going to be in addition to 2 liters of D5W that's going to be used over 2 days, and that's maintenance fluid. So this is not maintenance fluid. This is additional fluid that you're giving, that you're coming up with the Parkland's formula here. The maximum percent area for Parkland's formula is 50%. So if they have burns to 70% of their body area, you're still just going to use 50 here. So you don't ever use more than 50. And then you should subtract any fluids that have already been given. So if they've been given a bolus, you should subtract that from the total V. The formula calculates the additional fluids needed. It does not calculate for maintenance fluids. That should be added on if necessary. So how do we administer this? You're going to administer half of the V. So this V value is the amount you give over the first day, right? And the first half you give over the first 8 hours. The second half of that you'll give over the following 16 hours. And then you'll give half of that V volume over the following 24 hours on day 2. Okay, so half over the first 8 hours, half of it during the following 16 hours, and then half of the v-value over the following 24 hours. And in pediatric patients, instead of 4 milliliters per kilogram, use 6 milliliters per kilogram. And a good way, and really the way you're going to know if you're giving the patient enough fluids, is if they're creating enough urine. Adults should make between half and 1 milliliter per kilogram per day of urine. And children should make about 1 milliliter per kilogram per day. Okay, so let's do an example to make sure that we know how to use this properly. So here we have a 32-year-old man who's intoxicated and was witnessed to trip and fall into a bonfire. He's rushed to the ED via EMS. He's breathing adequately. There are no signs of smoke inhalation. IV access is obtained and routine labs are pending. NG suction has been placed. He is assessed to have sustained 2nd and 3rd degree burns to 15% of his body. He weighs 192 pounds or 87 kilograms. No fluids have yet been started. What should the starting fluid rate be? All right. So I'll let you go back, and if you want to read Parkland's formula again, you should memorize that though for the test. Okay, so let's go ahead and determine this. So Parkland's formula is the percent area burned times a kilogram body weight times 4 ml per kg in an adult, which this patient is. So that's going to be 15 times 87 kilograms times 4 milliliters per kilogram. And when you multiply that out, you get 5,220 milliliters. And we're using Ringer's lactate here. So we're giving half of the volume over the first 8 hours. So that's going to be our starting fluid rate, our first 8 hours. And half of that volume is 2,610 milliliters. And we're giving that over 8 hours. And so if you divide that out by 8, it comes out to be about 3,206 milliliters per hour of the Ringer's lactate. And then maintenance fluids if necessary. And by if necessary, some patients will be awake and able to drink oral fluids. If they have burns to more than 25%, or I think it's more than 20%, check me on that, but I think it's more than 20% of their body area, they're going to need to be placed on an NG tube, so you'll need to give them maintenance fluids. However, if they're burned to less than that, and 15% is definitely less than that, then they can take oral fluids. And so in that case, you wouldn't need to do maintenance fluids. But patients who are put on NG or patients who can't take oral fluids, you'll put them on maintenance fluids, and that would be D5W, and you'll just do it at maintenance rate, so 100, 125 milliliters per hour in an adult. So the first 8 hours is going to be 326 milliliters per hour, and then we slow it down. Okay, so we're still giving the same half of that V that we came up with, but then it's over 16 hours. So it's going to be half of the first 8 hours. So that's 163 milliliters per hour. And then day 2 will be the half of V given over 24 hours. So that'll be 81 milliliters per hour of lactate Ringers. And this is in addition to either oral fluids or maintenance fluids. And definitely, you've got to monitor the urinary output. So this is why we have a urinary catheter in the patient. Normal urinary output is half to 1 milliliter per kilogram per hour in an adult. So in this patient, he weighs 87 kilograms, so it should be anywhere between 43.5 to 87 milliliters per hour.